Welcome back. We are on session number 5 of our speakers for today. This is a spiritual and compassionate response to suicide. I'm grateful to have Dr. Stephen Lemmons with us today as our a speaker for this topic. I've known Dr. Lemmons for about 8 years now, worked with him at Caramount in the spiritual care department. Dr. Lemmons is the Director of Spiritual Care and Clinical Pastoral Education at Caramount Health in Gastonia. He joined the staff of Caramount in 2013. He's a South Carolina native. He completed his doctoral studies at Gardner-Webb, graduated from Erskine Theological Seminary, where he received his Master's of Divinity, and undergrad at University of South Carolina. He's an APC nationally board certified chaplain and an ACPE certified educator. Steve spent 7 years as psychiatric chaplain, where he led psychotherapy, grief, and spirituality groups. And he and his wife Jenny had a grown son, Scott, who died in 2011. Today, Steve and Jenny live on a farm in South Carolina with their 3-legged rescue cat, Oscar Wilde. Steve, we appreciate you being here today. Thank you.
And Lisa, I want to thank you for all the good work you've done putting this event together, and I think it's wonderful. And it's my privilege to be here today and speak to you for about 40 minutes or so. And I want to say I appreciate everyone who's joining us online for this seminar. And so we're going to spend about 35 minutes or so together this afternoon talking about suicide. And I'll leave about 10 minutes to try to answer any questions that you may have. And if you have any questions you'd like to email me. I'm going to give you my email address. It's steve.lemmons, Lemmons, @caramonthealth.org. Again, steve.lemmons @caramonthealth.org. Right. If you'll next slide, please. I'm sure that all of you have probably seen this picture of Dr. Breen, who was an emergency room physician at New York Presbyterian Hospital. And she was someone who treated a lot of coronavirus patients, and she contracted the COVID-19 virus. She was treated, she was able to be discharged, and was home about a week and a half, returned to work, and then her family, her father also being a physician, her father and family was able to get her to their home in Charlottesville, Virginia, where she needed rest and help. And her father said that she was detached. She had no history of mental illness. She described to her father the number of people that she had seen that had died before they could even be taken out of the ambulances at the hospital. And her father said that she was a hero who was caring for other people on the front line, and that she became a casualty too. She was described by her family as a devout Christian, someone who had a wonderful support group, had a good family. And it reminds us ER physicians in busy trauma centers face all kinds of horrible situations, but Dr. Green felt the weight of caring for her own colleagues, getting sick herself, and worrying about infecting other people. And she committed suicide on Sunday, April the 22nd, in Charlottesville, Virginia, where she was staying with family. Next slide, please. I want to give you a definition of suicide. Suicide is the deliberate human act of self-inflicted, self-intentioned death, a fully conscious human act carried out with the intention of terminating one's own life in the immediate future. Next slide, please. Since the beginning of time, there have been suicides. Two notable examples are that of Socrates and King Saul in the Bible, who is recorded for us. King Saul was the first king of Israel who fell on his own sword. Next slide, please. And other names of people that you are familiar, no doubt, to you, people like Virginia Woolf, Marilyn Monroe, Ernest Hemingway, and no slide of this one, but Robin Williams, another person that we are most acquainted with. Suicide as a problem. Suicide is a whispered word. For many people, it's an inappropriate word. Family and friends often pretend that they do not hear it, even when it's uttered. Suicide is really a taboo subject that stigmatizes not only the victim, but also the survivors as well. And there are emotions that surround almost all deaths. But when the death is self-inflicted, the emotions are intensified to almost unbearable proportions. People normally who commit suicide are generally under great mental strain, which they feel as incapable of being resolved. And if the person succeeds in taking his or her own life, those left behind not only experience the pain of separation, but also aggravated feelings of guilt and shame and anger and self-blame, raising questions for loved ones like why and what could I have done to help in this situation? What could I have done to prevent this? Survivors think, how can I face my friends? Next slide, please. For a moment, I just want to reflect on the number of suicides in the military. Next slide, please. From 2007 to 2017, the rate of suicide among veterans have increased by 50%. In 2017, an average of 16.8 veterans died by suicide each day. That's a staggering amount. Next slide, please. And religious leaders, one of the things that we know is that suicide is no respecter of persons. It involves people from all aspects of life. People of faith, people of no faith. It is something that is, as I say, no respecter of persons. Even religious leaders. Next slide. And I'm going to go through these quick. But David Treadway was a board member of the North Carolina Baptist Convention from Hickory, North Carolina, and he suffered with depression. Next slide. Ed Montgomery committed suicide about a year after the death of his wife, and in deep grief, in front of his son, he took his own life. Next slide, please. Melissa Page Strange, the daughter of Frank Page, who was the president of the Southern Baptist Convention in a few years past. Matthew Warren, son of Rick and Kay Warren of Saddleback Community Church, who also took his own life just after he had hung up the phone with his mother. Next slide, please. Our personal losses. Thomas Brindley wrote, "So relax your anguished heart. Live till fate decides your end. Do not make your own death, for that would be your greatest sin." Next slide. This is a picture of my uncle, who many, many years ago committed suicide. He committed suicide in the home. My mother was a witness to his death. He had a younger brother who was 12 years old who was a witness to his death. And this event has so shaped my family, my mother's family. She would not even would not even talk about her brother after this event had taken place. It marked her family for all the years of the rest of their life. Next slide. I also always think about this young man whose name was Tony Knight. I was a high school teacher for 5 years, and he was one of my students. In fact, I had him in class for 2 classes a day. And I remember the day very clearly when Tony took his own life, because he asked if he could talk to me after class. And he asked me a series of questions that seemed like to me to be hypothetical questions. And I answered them the best I could. But it was only the next day that I had learned that of his death. And later I was to learn that the very questions that he had asked me about were the questions that he and his family were really struggling with. And like so many other people, have asked myself so many times how I could have responded differently in a way where the result would have been very different. Next slide, please. I want to talk a little bit about the statistics of suicide. Next slide. From 1999 through 2018, the suicide rate has increased in the United States by 35%. There's about 48,000, in 2018 there was 48,344 suicides. That's 131 per day. That is one person committing suicide in our country every 11 seconds. One elderly person who commits suicide every 1 hour and 34.7 minutes. It is the 10th ranking cause of death in the United States. Next slide. And some statistics about youth and suicide. For youth, ages 10 through 34, suicide is the second leading cause of death in the U.S. in 2017. These are the latest CDC statistics, by the way. Number one for the people in that 10 to 34 year age group is accidents, and number 3 is homicides, suicide being the second most frequent cause of death. 14,717 suicides in 2017. 40 suicide deaths every day by someone ages 10 through 34. 1 suicide every 36 minutes. And a nationwide survey of youth in grades 9 through 12 in public and private schools in the U.S. found that 16% of students reported seriously considering suicide, and 13% had reported that they had created a plan for carrying their suicide out. And 8% reported trying to take their own life in the 12 months preceding the survey. In terms of LGBTQ youth, next slide, there, thank you. Lesbian, gay, bisexual, and questioning youth are 5 times more likely to attempt suicide. In a national study, 40% of transgender adults reported having made a suicide attempt. 92% of these individuals reported having attempted suicide before the age of 25. Statistics by gender. 3.7 male deaths by suicide for each female death by suicide in 2018. White males accounted for 69.67% of suicide deaths in 2017. And the rate of suicide is highest in middle-aged white men in particular. in terms of attempts, there are no real, these are just estimates because there's no data that's really national data that's compiled about this, but it's estimated that 1.4 million suicide attempts were made in the U.S. in 2017. An estimated 5 million living Americans have attempted suicide. Now, some Gaston County, North Carolina studies. The rate of suicide in Gaston County is higher than the national average. It's higher than the North Carolina average. The North Carolina rate of suicide average is 14.28 per 100,000 people, just above the national average. The Gaston County suicide rate is higher than both of those at 25.67 per 100,000. In terms of comparing Gaston County, where the suicide rate is compared to the other counties, the 100 counties in North Carolina, Gaston County ranks as the 33rd highest, the 31st highest rate of counties out of the 100 counties. Cleveland County scores at 33rd, and Rutherford County scores as 15th highest county for suicides. Now, there's some warning signs for suicide. Mental research shows that mental health diagnoses are associated with a higher rate of suicides. A high rate of suicides are completed by people who have a mental health diagnosis. And diagnosis groups that are particularly at risk include those with depression, schizophrenia, drug and or chemical dependency, and conduct disorders in adolescents. And there seems to be a relationship between depression and suicide. The risk of suicide is increased in depressed individuals. On an average, about 60% of suicides are committed by people who are said to be depressed. And there's also a relationship between alcoholism and suicide. The risk of suicide in alcoholics is 50 to 70% higher than the general population. Also, people who have a sense of feelings of hopelessness, where they feel there's no solution to the problem, are found to be more predictive of suicide risk than a diagnosis of depression. Socially isolated individuals are also people at risk. And the vast majority of individuals who are suicidal often display clues and warning signs. Individuals may display one or more of the problems or signs that we're about to discuss. The following list describes some potential factors of risk for suicide. And if those are observed, it's recommended that professional evaluation be conducted. By the way, I want to mention to you, those of you who are interested in learning more about how do you as an individual approach someone that you think might be suicidal. Lisa has a workshop that she's scheduled, I think, for the fall coming up. It's called QPR, and I've attended this, and this is an excellent. It's a very short seminar. It's like in an afternoon, maybe just about 2 or 3 hours, I think. And QPR, question, persuade, and refer. And one of the things that I remember the most out of this seminar is how helpful this is of helping people, of questioning the person that they think might be suicidal, and asking straight out the question about, and teaching you ways of doing this, of asking the individual if they have thought about harming themselves, if they have a plan, and then working with them to try to refer them to someone else. It's excellent, and I would recommend it. And Lisa could give you more information on the date and time of the next QPR Institute seminar. So I wanted to mention that to you. The presence of a psychiatric disorder like depression, drug or alcohol addiction, behavior disorders, conduct disorders, runaways, youth runaways, for people who've been incarcerated. All of these can be people who are more at risk. The expression, communication of thoughts of suicide, death, dying, conversations about the afterlife, especially in the context of sadness, boredom, hopelessness, or negative feelings, all may be clues. Impulsive and aggressive behavior, frequent expressions of rage, increased use of alcohol or drugs, someone that you notice is stockpiling pills, significant, real, or anticipated loss, family instability, significant family conflict. All of these are symptoms of someone who may be more at risk. I want to talk for a moment about suicide as a theological concern. The church often articulates that suicide is the result of mental illness, and therefore the person should be forgiven on that ground. Is it possible for a person to be suicidal and rational? It's a good question. And if so, then what are the applications for spiritual care, if that's true? The Bible is present for Christians and Jews are surprisingly silent on the issue of suicide as a moral or ethical issue. There are a few instances that are mentioned without moral judgment. But the first Christian writings that we have that appeared that spoke about suicide and judgment against suicide came from the early church in dealing with martyrdom. St. Augustine was the first theologian who took the position that suicide is an affront to God. Then after Augustine, the church took an increasingly strong stand against suicide as being a sin. And for many centuries, the church would not allow people who committed suicide to be buried in their churchyard. Instead, those who committed suicide were buried outside the churchyard with others, like criminals and others that they would not allow to be buried in the church cemetery. Church attitudes toward suicide have changed considerably since the late 1800s, when suicide which suicide was still considered to be, by most churches, to be a mortal sin. And those who died were not given a proper burial. A shift in attitude began in the church around the time of Sir Thomas More, who, by the way, has nothing to do with this lecture, but my wife is a direct descendant of Sir Thomas More. And by the way, when I discovered that and shared that with my wife, she was not impressed at all. Just an aside. But Sir Thomas More, this is who lived from 1468 to 1535, and also through the writings of John Donne and Hume and Kant, all of whom opposed the church's condemnation of suicide as a sin, and began to think about suicide as an aberration of mind which should be treated tolerably. And from this tolerance grew the modern view that suicide represents disease and should be treated as such. And there is also today a strong view that suicide represents neither sin nor does it always represent a mental disease, but is sometimes a rational choice. And just quickly, in terms of other religions, for instance, Jewish views on suicide. In Orthodox Judaism, suicide is forbidden by Jewish law and viewed as a sin. But non-Orthodox forms of Judaism may instead recognize the act as more akin to a death by disease or disorder, except in cases of what they consider to be purposeful assisted suicide. Rabbinical scholars command compassion for both the deceased and the survivors. Islam's view on suicide, Islam clearly forbids suicide, and there are verses in the Quran that speak to this. Buddhism looks negatively on suicide with their strong emphasis on life and also karma, that they believe that in certain circumstances that it can affect the future for the individual. Hinduism also looks negatively at suicide for some of the same reasons. And they see it as someone akin to the same thing as someone who takes the life of another person. We'll move to talk a bit about spiritual interventions. Intervention refers to secondary acts of prevention specifically designed to stop suicidal acts already in progress. A spiritual, compassionate understanding is needed. Depression and isolation. Most suicidal persons are lonely, depressed, experiencing hopelessness, helplessness, and anger. In some cases, they've experienced these thoughts for years and have self-medicated for years. And the person sometimes feels that he or she can no longer cope with the pain and the stress. And often depression is in response to some loss or series of losses which are emotionally significant to them, such as a relationship, the loss of a relationship, the loss of their health, their job, their reputation. Ambivalence is another matter. Most suicidal persons are ambivalent about dying. The desire to live or die is in conflict. Most suicidal people are not so much wanting to die as they are willing to die as a necessary price to escape this endless pain that they feel they're in. Crisis. And most suicidal attempts are made during a relatively brief period of time when the emotional pain peaks and their coping skills are low. And the duration of this may only be for a few hours and a few weeks. And that's why intervention is so important and so effective. Spiritual understanding is needed. Communication. Often the suicidal person makes overt and covert attempts to communicate the pain that they're in, and sometimes that's referred to as the cry for help. And that can include multiple doctor visits with vague symptoms, making a new will, giving away possessions, careless medication, and non-lethal suicide attempts. These all may be attempts to communicate to loved ones and perhaps even to God. Listening. This is an important intervention because suicidal behavior is at a heart to attempt to communicate distress. Most suicidal people respond well when they encounter what the theologian Paul Tillich referred to as a loving listener. A loving listener. The listener needs to be someone who can put away other concerns and judgments and gently inquire into suicidal thoughts. And then there needs to be an assessment, assessing the suicidal risk. Is there a suicidal plan? And this is key. Most suicidal people have given a lot of thought and preparation to the plan. And they're honest about the plan when they're asked by a loving listener who is showing genuine concern for the person. The more specific, the more deadly and available the means, the greater the risk. Other factors include their stress level, their low personal resources, previous attempts, and the use of alcohol and illegal drugs. The intervention plan. Because a suicide crisis represents high risk for a relatively short period of time, the spiritual, compassionate plan needs to focus on immediate issues and be implemented quickly. A list of all resources should be developed, which include personal relationships, professional relationships, community resources. The suicidal person should participate in every phase as much as possible of the development and implementation of this intervention plan. And good follow-through is so important so that there's no opportunity for feelings of abandonment. And of course, referral. Referral in all high-risk situations, professional referral is needed and should be sought. Therapy using, among other things, focusing on building protective factors and reducing risk factors through a variety of different approaches. This will also include suicide hotlines, aerial mental health, pastoral counselors, psychiatrists. And if you are looking for a list of counselors, a referral list, write to me. I'll send you our list that we use. Suicide prevention. Know the diagnostic warnings. And there may be verbal and behavioral warnings. Situational clues are more difficult. For example, when a patient is told that they have a terminal illness or divorce papers are served, the executive is fired. Some of those are more difficult sometimes to know about. Clues are given, though, by physical and emotional symptoms. 3 symptoms that should be carefully watched: depression, disorientation, and defiance. And we have an opportunity to teach the warning signs to other people, to help them understand. Also, establish a caring relationship. We take the initiative in expressing concern for an individual who is suicidal, and that includes, as I said earlier, loving listening, raising the questions about suicide with the individual, making a contract with the suicidal person, to continue the relationship even in the midst of the crisis, to offer to pray with the person as an expression of pastoral concern, respecting the need of confidentiality, but avoid agreements to keep you from seeking help from others if that need exists. Develop a therapeutic plan. Through the relationship, we can help the person accomplish specific teachable steps in altering behavior and responding to problems. Again, referral is the key. Now, in terms of care to the survivors, suicide survivors perceive that they receive less social support than other people who are grieving. Many who want to reach out, but they're afraid of helping survivors, thinking that we're going to say the wrong thing. And so often, even in the church, there's so little attention that are given by church and congregational members toward the survivors of suicide. Is suicide a private matter? Some people, and a lot of times, a lot of the 20th century, many people thought of suicide that way, that the person has the right to choose to end their own life. But today, with greater understanding and understanding of mental illness, and more people understand that suicide is not a private matter, that each suicide, on an average, affects at least 6 other people So based on the number of suicide attempts in the U.S., we're talking about 5 million people. 1 out of every 62 Americans who are somehow affected by suicide every year. And those questions that come to those who are close to the individual, those questions of why and what could I have done to prevent it? Survivors ask the questions, how can I face my friends? What will they think of me? Help survivors to heal. How can you help? Accept the intensity and complexity of the grief. Listen with your heart. Avoid simplistic explanations and cliches. Be compassionate. Respect the need to grieve. Understand the uniqueness of suicide grief. And be aware of holidays and anniversaries. Be aware of support groups. By the way, I don't think we have a support group. If someone knows this, please let me know. In Gaston County right now, we have had in the past, but I know there's support groups in Charlotte. But be aware also of respecting their faith and spirituality and work together as helpers. I know this was quick. We moved through it, but that's it. And thank you for your attention. I think we might have our questions.
Thank you, Steve. Really important topic to talk about. One thing I found most interesting is I've had this event planned for a very long time. And unfortunately, one of the speakers that I had lined up for one of the slots today, I had received notice several months back that she was not going to be available. She had died unexpectedly. And I later learned that it was of death by suicide, and just really impacted me even more about the importance of this event itself today, that even people within the profession of behavioral health, have resources and also have problems. And so just the importance of being mindful of that to you. So if you would like to address some of the questions there.
I'll take the first one, and the question is, how would one encourage another to participate in an intervention plan? I think this is probably coming from the comment that I made where I said that as much as possible involve the suicidal person in the intervention plan. And I'll try to answer it that way. And that's a great question. And I've seen, let me just simply say to start with, I've seen the value of involving people who are really struggling with depression and grief to be involved in their own intervention plan. When I was working as a chaplain in the psychiatric unit at Palmetto Health, and Prisma Health now, in Columbia, one of the things that was done in our interdisciplinary meetings that I've never had anywhere else, we would bring the patient in to participate in their own plan of care. And I became a great believer that if that can be done, that can be a really helpful thing to the individual. And I think one of the things that it does if we can involve the person, if they're willing to be a part of perhaps sitting down and talking about the intervention plan, is it helps them to see our own care and our own investment in what we're willing to do to help this person. But to also to get them to talk about what they need and how perhaps a better way that if I'm the one who is trying to help the person in this intervention plan, to help me understand what will best help you. And I don't think that always the person might. I think sometimes they may not be able to or be willing to participate, but I would certainly encourage you to try to bring the person in. And so that's my idea, is get the person in on the discussion about sharing what you're thinking, what the plan needs to include, and bring that person into the discussion about it. What can we do to support what can we do to help support the survivors of suicide? Well, you know, one of the, I would say the most important thing is communicate. I remember a couple, an older couple, and both of them are deceased now, who had a son who had committed suicide. And I remember visiting them in their home and talking to them because I knew her son. And talking to them, and his name was Steve, talking to her about Steve. And I'll never forget this. The mother said to me, "You do not know how much it is helping me to talk about my son." Because she said, no one at church wants to bring him up. And she said, I love to talk about my son. And so that's the big thing that I would say right off. Don't hesitate about talking to the person in a loving, compassionate way about the person in their life that has committed suicide. Chances are they may want to talk about the person, and you'll create a sacred space where they can discuss with you and talk about you, and a holy space to talk about their loved one. So take a risk. You know, how do you assist a person who is experiencing severe guilt in a family suicide? You know, I can't ever remember being with a family that where their loved one, a son, a daughter, a husband, or a wife, where there was not a lot of severe guilt and questioning about what I could have done differently. And it's a natural thing for people to ask those questions. It's the same thing that we hear constantly when someone comes in with a heart attack in the ED, a wife or a husband who says, I should have made her or should have made him come into the hospital. But we know that they could not have done that. But I think allowing that person to express what they're feeling and going through and to get it out, because I think one of the things that we don't do a disfavor to people if they are wanting to talk about the guilt that they feel by stopping them from doing that and just saying, oh, you don't need to worry about that because you're fine, you didn't do that. I think there is a value in creating a space for confession. Even if it's that they may hopefully will come to a point of understanding that really that they could not have prevented it, but helping them to work through it by allowing them to talk about the guilt that they feel. Hearing it, honoring it by listening. Talking about the shocking statistics about suicide. They are shocking, indeed, and the prevalence and the growing number, the increasing rate of suicide is discouraging, very discouraging. I agree. You know, the question about why do I think there's that group of middle-aged white males are the most, there are more suicides in that group and gender and race than any other. I'm really not sure completely. That's changed over the years some. In past years, I realized about 10 years ago, if I'm not mistaken, the last report statistics that came in, around 2010 or so, showed that even older adults were, I think, in the highest group. But I'm really not sure myself. That's a good question. And sorry. By the way, I want to apologize for the typos in the slides. There's a few typos, but I'm going to tell you, at 1:30 in the morning when I'm getting them in at the deadline to get them to Lisa, they look pretty good.
No one even noticed typos. Thank you for getting all of the information into me. I did have some good deadlines for my speakers, and they were wonderful to get everything to me so that we would have it prepared for today. But again, thank you, Steve, for being here today. It was a pleasure having you.